Uh, Good evening, everyone. I welcome you all for today's Aurangabad Urology Association's meet. We will straightforward start with the topic. Today there is a symposium on inflammatory stricture urethra, for which I would like to call upon the moderators of the session, Dr. Martin Patil sir, Dr. Venkat Gite sir, and Dr. Om Prakash Mundada sir. And for the first talk, I would like to call upon Dr. Subodh Patankar. He will give an overview of surgical anatomy of urethra.
Good evening, everyone. Good evening, my seniors, my teachers, and my fellow colleagues. My topic is overview of surgical anatomy of urethra. Male urethra, length is 20 centimeter, diameter is around 8 to 9 mm. It is contained within the vascular corpus spongiosum and the glans. It has divided into two parts, anterior urethra and posterior urethra. Anterior urethra, bulbar, penile, and fossa navicularis. The extent is from begins at the perineal membrane to urethral meatus. The posterior urethra it begins from the distal to the bladder neck to the perineal membrane. So this is a schematic diagram showing the parts of urethra. The arterial supply is from internal pudendal artery, which gives bulbourethral branches. Bulbourethral arteries is at the 3 o'clock and 9 o'clock position. So in visual internal urethrotomy, the incision is taken at 12 o'clock to avoid bleeding. Venous drainage is pudendal plexus, which drains into the internal pudendal vein. Lymphatics, they drain to internal iliac, hypogastric and common iliac nodes. So the first part of anterior urethra is fossa navicularis. It is a granular portion of urethra. It is wider in caliber compared to proximal urethra. Muscularis mucosa is absent. There are multiple pockets on the dorsal and lateral surface of fossa navicularis. The one large pocket, which is known as lacuna magna, it opens on the roof. So navicular shape of the fossa and its elliptical external opening allow urine to be expelled at higher flow rate. So it is a flow control chamber. So stricture can happen in long-term catheterized patients and post URP. There may be impaction of stone at the fossa navicularis. Then penile urethra, it is 15 centimeter in length. It is also known as pendulous and spongy urethra. Extent is from the suspensory ligament to the meatus. Muscle layer is made up of inner longitudinal, middle circular, and outer longitudinal layer. Bulbomembranous junction is 2 centimeter in length, and it is within the urogenital diaphragm as well as the striated urethral sphincter. Then glands of Litter, small mucus secreting cells which lubricate the urethra before ejaculation and empty into orifices on the posterior wall. Bulbourethral glands present at the 3 o'clock and 9 o'clock position. The arterial supply of penile urethra is direct branches of internal pudendal artery. Venous drainage is from dorsal vein of penis to internal pudendal vein to prostatic venous plexus. Lymphatic, they drain into deep and superficial inguinal lymph nodes. Now membranous urethra. This is again an important portion of urethra, 2 to 2.5 centimeter length. It is shortest, least dilatable, and it is the fixed part. That is why it gets damaged during pelvic trauma. Extent is from prostatic apex and perineal membrane. It has a thin, smooth muscle layer, an outer layer of circularly arranged striated muscle, which reaches from the base of the bladder and anterior aspect of the prostate, extending in the complete length. It is signet ring-shaped striated sphincter. The external urethral sphincter mechanism consists of three parts: urethral smooth muscle, urethral striated muscle, pubourethral portion of levator ani. Striated muscle fibers are mostly of the slow twitch type, allowing for a sustained urethral compression. The deep dorsal vein of the penis passes anterior to the urethral sphincter and membranous urethra. The continence after radical prostatectomy and cystectomy with bladder substitution seems to depend on the anatomic and functional maintenance of the membranous urethra. Neurovascular bundle also course through at the 3 and 9 o'clock position along the membranous urethra before they penetrate the crura of penis. Arterial supply is bulbourethral artery, which is a branch of internal pudendal artery. Nerve supply is pudendal nerve. Somatic innervation is via sacral plexus, the ventral root of S3 and S2. The sensory innervation from striated sphincter, they travel to the pudendal nerve via S2, S3 to the node of Onuf. The lymphatics through the external iliac nodes. This is a cystoscopic appearance of the striated sphincter. Now the prostatic urethra, it begins as a continuation of bladder neck and passes through the prostate. It is widest and most dilatable portion. It has got a urethral crest which is present throughout the length of prostatic urethra, and it projects into the lumen, causing the lumen to appear crescentric in transverse section. Then there are prostatic sinuses which open on posterior wall. Then urethral angle. The angle at the midpoint of prostatic urethra turns 35 degrees. It ranges from 0 to 90 degree anteriorly and separates the prostatic urethra into pre-prostatic and prostatic part. So the pre-prostatic part is it is made up of thickened circular smooth muscle, which is synonymous with internal urethral sphincter, and it prevents the retrograde flow of ejaculate into bladder, and it maintains urinary continence. Prostatic part is 3 to 4 centimeter, and it is innervated by motor somatic fibers with an absence of any autonomic innervation. So this is a schematic diagram showing posterior wall of prostatic urethra. Verumontanum, colliculus seminalis, which is the important landmark during TURP. It is widening and protrusion of urethral crest from posterior wall. Prostatic utricles are the Mullerian remnant, and it appears like a slit at the apex of verumontanum. So ejaculatory duct openings are located on either side of utricle orifice. Arterial supply is through the inferior vesical artery, which is a branch of internal iliac artery, and lymphatics, obturator and internal iliac nodes. Now coming to female urethra, which is 4 centimeter in length. It is lined by transitional epithelium above and squamous epithelium below. It begins at the neck of the bladder and passes inferiorly through the perineal membrane and muscular pelvic floor. It is surrounded by erectile spongy tissue that is anatomically continuous with glands of the clitoris. So there is a sleeve of smooth and striated muscle fibers surrounding the spongy tissue, which contains fast and slow twitch fibers similar to those of the intramural sphincter of male membranous urethra. Then Skinner's gland, the mucus secreting glands which lie either side of the urethra. The arterial supply to female urethra is internal pudendal artery, vaginal artery and inferior vesical branches of vaginal arteries. Nerve supply is through the vesical plexus and pudendal nerve, and the lymphatics through the internal iliac and superficial inguinal nodes. Thank you.
Thank you, Subodh. Now I would like to call upon Dr. Anubhav Das. He will be talking about evaluation of stricture.
Sorry, there is a little bit of technical glitch. I will require 1 minute. Just few last moment changes. एक स्लाइड खाली ऐड करना था सर. Good evening, faculty members and my dear colleagues. Today I will be presenting on the evaluation of urethral stricture. The evaluation will be covered under clinical history taking and findings on physical examination, radiographic techniques, endoscopic techniques, urinary flow studies, and other investigations. First of all, in other investigations, generally we will require blood urea, serum creatinine to rule out any upper urinary tract damage, urine culture sensitivity of midstream urine to check for UTI, and serology to exclude any venereal infections, and USG KUB for stone or evaluation of blood pressure changes on upper tract. This is the classification of degree of urethral narrowing by EAU. Category 0 is normal urethra on imaging. On category 1 there is subclinical strictures in which the urethral lumen is more than 16 French, but it's considered as a low degree. On second category it's low grade stricture in which the urethral lumen is 11 to 15 French. In third grade, high grade or flow significant strictures are generally 4 to 10 French urethral lumens, and near obliterative strictures are generally 1 to 3 French. And there are oblative structures in which none of the urethral lumen is seen, 0 French. It's considered as, these three are considered as a high degree of urethral narrowing. On clinical features, we can see for the symptoms, the patients will present with gradual diminution of force and caliber of urinary stream. It will be most common presentation of the patients. And there will be a sudden, sometimes there will be sudden urinary retention. And then there can be patients' symptoms of cystitis, frequency, urgency, and nocturia. And mostly they will come with obstructive LUTS. On radiographic evaluation on USG KUB we can see for significant post-void urine, and on sonourethrogram it is done by a 7.5 megahertz probe, and it evaluates generally a distal bulbar and penile urethra, and the location of the stricture and the length evaluation of the stricture can be done on USG. This is the Devine's classification of degree of spongiofibrosis, and there are 6 types: A, B, C, and 2F. A is mucosal fold, B is iris-like constriction, C is full thickness involvement with minimal fibrosis in the spongy tissues, D is full thickness spongiofibrosis, E is inflammation and fibrosis involving tissues outside the corpus spongiosum, and F is a complex stricture complicated by the fistula. This is Mechanic and classification on USG. The urethral lumen one is normal, and a mild stricture is considered to be the lumen if it's occluded less than 1/3 of the lumen capacity. Moderate stricture is generally 1/3 to half of the lumen occlusion, and severe is more than half lumen we occluded, considered as severe grading. On radiographic evaluation on X-ray, one of the methods is ASU, or also known as RGU, ascending uretrogram or retrograde urethrophy. It is generally done to evaluate the ascending anterior urethra, in which the anterior part of the urethra we can see the penile, any strictures in the penile region or the bulbar region can be seen. It is not, we cannot comment on the posterior urethra. For posterior urethra, generally MCU it needs to be done. On MCU, the posterior urethra can be seen dilated before the stricture. On MRI can be used as a modality which is used very rarely in post-traumatic pelvic anatomy, length of the postmembranous defect, and should be used in conjunction with ASU and MCU to determine the surgical approach. On endoscopic evaluation, we can use flexible or rigid urethroscopes to do cystourethropy. It confirms the diagnosis very precisely. On urine flow studies, uroflowmetry gives an objective measurement of the degree of obstruction, and any changes occurring subsequent to the treatment can be assessed with uroflowmetry. You can see the graph. The typically long, slow, protracted flow pattern is seen with a plateau appearance. Typically flat, box-shaped uroflowmetry pattern is typically present in patients of stricture urethra. This is a diagnostic. This is the diagnostic flowchart of patients which are suspected present with urethral stricture disease by EAU guideline. When a patient present with voiding symptoms, generally we advise uroflowmetry with USG to see for post-void residue. And if stricture pattern is seen or stricture disease is suspected, then we can advise the patient for radiographical investigations like ASU or MCU. And if any equivocal test is seen on this test, then a cystoscopy can be done to evaluate and confirm the diagnosis. If a stricture disease is seen, then it will be critical in decision making to find out the degree of spongiofibrosis, the exact stricture length, and periurethral pathology if at all suspected. And after confirming the diagnosis, we can plan for the management of the stricture disease. That's all for me in evaluation of strictures. Thank you, sir.
Thank you, Anubhav. For today's third talk, I would like to call upon Dr. Altaf. He will be talking about endoscopic management principles and options.
ये मेरा नहीं है, इसका बंद हो गया एंडो मैनेजमेंट डेस्कटॉप्स एंडो मैनेजमेंट या नीचे इसको पुल कर देना यार इसके वायर का ये हो रहा है क्या ये स्क्रॉल करना है क्या ये करना है ये डाउन ये नेक्स्ट अच्छा good evening respected seniors colleagues and my residents. I'm going to talk on endoscopic management of inflammatory urethral strictures. When I was preparing the slides, I was a bit confused because inflammatory strictures nowadays, because of the STDs and gonococci are very less. What we come across is a lichen sclerosis. But overall, I'll be dealing with the conventional and more commonly used modalities and newer recent advances in it. So why we opt for the endoscopic management is its ease of procedure, technique, less invasive, less time consuming, less operative time and perioperative course. And when the specialized center or the surgeon is not experienced enough for the complex urethroplasty, it can be offered to the patients. And also patient's personal preference when he doesn't have to undergo the extensive procedures and take a risk. And when the patient is unfit for the complex definitive procedures, we can offer these modalities. We trace the history, it has been practiced, and first two is named the Shushruth. We are proud to have legendary medicine and surgical person. He developed the alloy with iron, and he used to dilate from the meatus to the bladder neck, blind dilatation, and used to every lubricant is used as a butter or ghee, sometimes oil. And every third day he started progressively increasing dilator size. So he's the first person documented in history to performing of urethral dilatation. Then involved in 1719, John Douglas, he passed a soft catheter and he palpated suprapubically to incise on it. But because of the high mortality, this was abandoned. The first one to perform the direct visual internal urethrotomy is Felix Oberlander in 1892 with his urethrotom and optical light. It was the first visual. Previously they were doing the blind procedures with a high complication rate. And before all the management, we need to understand the pathophysiology of stricture disease and the application of the wound healing process. We can target various mechanisms through the new chemotherapeutic agents which can be used along with the dilatation or DVIU. The first is, as we know, the first process is after the trauma or insult of anything. There is a hemostasis and there is a clot formation where there is a vasoconstriction and there is a platelet aggregation with a degranulation and fibrin formation. Second is inflammation where all the neutrophils, fibroblasts, histiocytes, mast cells, they come, they proliferate, they degranulate, and there is a release of various cytokines, interleukins and growth factors. Third is a proliferation. When there is a the fibroblasts take over, they start forming the collagens. Main collagen which is formed in early phase is a type 3 collagen, which is a more stiff, and there is a extracellular matrix formation from these cells, and then the wound undergoes remodeling, which more mature natural tissue it's formed over a period of time, where type 3 collagen is converted to type 1 collagen. In normal urethra, we have 75% of elastic type 1 collagen, and in stricture, the studies have found 84% of type 3 collagen. So the various cells which can be targeted with the adjunct of chemotherapeutic agents. The main targets are macrophages, monocytes, and fibroblasts. The post 2 weeks after the injury, the fibroblast with the under the influence of PDGF and TGF, they converts in myofibroblast with more active microfilaments, which helps in the tissue contraction. There are the contractile forces. So they have studied in skin, the actual rate of contraction is 0.7 mm per day, but this is for the skin. It is not, the studies have not done for the urethral stricture. But the same, the scar composition in the normal tissue, and which I have already explained. So what options we can offer? We have dilatation, DVIU, and with these two commonly performed procedures, we have adjunct of intralesional steroids and various chemotherapeutic agents. We can use urethral stents. Nowadays, there are drug-coated balloon dilatations with paclitaxel, and the endourethroplasty with a lot of genetic tissue cultures and genetic science has come into picture. So first and foremost, which is very easily done OPD procedure, dilatation. It stretches the urethral mucosa and the scar is disrupted, with the hope that reepithelialization occur faster than the wound contraction. If it is done blindly, there is a chances of bleeding, perforation. So it is better to be performed under vision over the guide wire. The success rate varies from 23 to 64% in various studies. The next most commonly performed is a DVIU. It is difference between dilatation and DVIU is there is scar dilatation. Here the stricture is incised. With the same principle, the epitheliation should occur before the contracture of the scar. The only one high-level evidence study to support this, where they have randomized to 10 patients with the non-obliterative bulbar strictures at all the locations, and they have compared dilatation with DVIU, and they have followed up with the retrograde urethrograms at 3, 6, 9, 12, up to 4 years they have followed, and they have found 60% patency rate at the end of 1 year. It is the only unique study randomized which shows that dilatation is equally effective with DVIU. Both are less effective if the stricture length is increased and it is performed frequently. So which patients are most likely to succeed with the DVIU as an initial procedure? So Barbagli has reported ideal patient who succeeds, which we can counsel beforehand, is a single shot, ideally less than 1 centimeter, but up to 2 centimeter bulbar stricture without prior intervention. Up to 71% of patency rate can be expected. Lot of studies have compared. It is the efficacy is between 8 to 77% after DVIU. The median time to recurrence is less than, in most of the series, recurrence occur within 1 year. So it is also tested as a salvage procedure in recurrent strictures and also in the failed urethroplasties. There was a trial conducted, open trial, where they have defined the recurrent stricture as at least one procedure's previous failed intervention, either endoscopic, DVI, urethral dilatation, or urethroplasties. So in those patients, selected patients, so what was the outcome? There can we can expect from 0 to 40% patency rate, but the success decreases as the number of procedures increases. So only ideal patient in post urethroplasty patient is there is a short diaphragm like narrowing, either the anastomotic ends, proximal or distant. There we can expect a good outcome. So in those patients, 43 patients studied, less than 1 centimeter of wheel-like diaphragm, DVI yields 51% of success rate. One important thing we have to keep in mind, repeated urethral manipulations, either in the form of dilatation, VIU, can increase the stricture complexity and the success rate of further urethroplasties. So, what are the ways? We have cold knife or we have hot. Hot includes laser. With lot of lasers, we have holmium, thulium, and also can be done with plasma kinetic. So which one is superior? So there is the studies ultimately it says there is we cannot recommend any studies which can make a favor in favor of any technique which is superior to another. And all they have compared the results. Laser yields a slightly better advantage with a success rate of 58% at to 42%, but they do not support the efficacy of one technique of DI over the another, and given the similar complication rates. Complication rates in most of the procedures are less, but we expect less bleeding in laser, but more extravasation is also reported in one studies. So what are the we can summarize or we recommend is it should not be DVI should not be performed in penile strictures, because there can be extravasation and urine it can cause risk of erectile dysfunction because of the venous leakage. Then increased stricture length is associated with the high risk of failure. Ideal patients are less than 2 centimeter. DVI has a stricture free rate of 51% if performed in recurrent patients. And there is a conflict evidence of hot, either laser or plasma kinetic DVI superior to cold knife, but there is only one studies. So the strong recommendation is do not use it in penile structures and do not do it in more than 2 centimeter of the strictures. So to increase the success rate or yield, we have to interlesional a lot of other modalities along with this. The patient which are we cannot post for erythroplasty or they don't opt for any other adjuvant therapy, they are recommended. This is many patients, all of us have this. We advise patients to dilate. What is the evidence is recommendation of self catheterization after DVIU. To maintain the temporary urethral patency rate. It has shown if the patient is advised to at least 4 months of weekly or bi-weekly regime, there is a better self-patency rate. We can use steroids, mitomycin C, paclitaxel, platelet-rich plasma. The role of steroids particularly is useful in inflammatory stricture due to lichen sclerosis. We can avoid complex surgeries because the recurrence even in buccal mucosal erythroplasty is very high. So those patients with meiotomy circumcision along with the intralesional steroid installation, the studies have shown a better stricture free rate. And only in patients with repeated UTIs, sepsis and retention, we should offer them a urethroplasty. Experience is limited and it is used all of these agents, they are off-label use of these drugs, and there is still a significant uncertainty about ideal dose, schedule, volume and technique. So urethral stents again one of the options in the patient. With the principle is that after performance of DVI or dilatation, it opposes the wound contraction because of these mechanical properties. They are classified as a permanent or temporary stent. The time which we keep the patient in up to 12 months, it is said as a temporary stent. Permanent stent, as they are having high rate of complications, so generally recommendation is that we should not use it. Stents have a high failure rate in penile urethra, and temporary stents prolong time for next recurrence as compared to the dilatation or DVI alone. So it is only used when you don't have definitive option. Now we have drug coated balloon dilatation, that is with paclitaxel. It is a newer modality. Paclitaxel is a antimitotic. It inhibits a tubule formation. The principle is it is usually now recommended only in bulbar strictures of less than 3 centimeters. The trial is a robust trial where they have studied 127 patients. The mechanism is either you have to in recurrent strictures with either failed DVI or urethroplasty, you dilate the stricture with either DVI or VI, you do it. Then under fluoroscopic guidance, the balloon is inflated to the pressure gauge, and it the drug delivery is diffuse over a stricture length, and it prevents the scar formation. That is a principle. So the overall efficacy rate is good at the end of 1 year, 83% were stricture free, and long 3 years data is available. We have 67% functional success. So what is endourethroplasty? So now genetic engineering and stem cells, this concept is booming up. There is a promising alternative for the open substitutional buccal graft urethroplasty. The autologous cultured buccal graft, they are cultured in the tissue culture labs, and they are made in a scaffold of TGF, that is thermosensitive gelatin polymer, and they are either after the dilatation DF, they are under vision, they are put there, and we expect that they cover the epithelium and prevent the fibrosis there. So we have various studies. One of the studies done by Surya Vaddi, he did 6 patients. In redo surgeries, the average length was more than 3 centimeters, and he had a good success rate in 4 patients. And there is a, again, they have done the same in rabbit. They have induced artificial strictures. They have injected the say buccal graft, and they have shown the good results, promising results. Again, we have seen the endourethroplasty with the, in the case of recurrent engraftment, mesh skin graft can be also used as a endourethroplasty, and generally the data is available for bladder neck contracture patients in post radical retropubic prostatectomy patients, and they have good outcome. Thank you.
Thank you, Altaf. Now I would like to call upon Dr. Arun Chinchole. He will be talking about BMG urethroplasty.
Good evening, respected seniors and dear friends. So, my topic would be to speak on BMG urethroplasty, which is very interesting, and what, as a being a surgeon, we are interested in this topic and this subject. So, I will directly go to the topic, and before that, a principle on which the BMG urethroplasty is based is the Duplé-Dennis-Brown principle. What he says, that when a epithelium or a piece of a epithelium or a mucosa, it grows into a epithelialized tube or epithelialized surface over a period of time. So first urethroplasty, dorsal urethroplasty was performed in 1980 by Mansour, where he just opened the dorsally the urethra and sutured it to the spongiosum without any graft. But in 1996, the actual procedure of dorsal only urethroplasty described by Barbagli, and from there the journey of BMG urethroplasty has started. What are the indications? As Altaf said, that those who are not indicated for DIU are all the options for or indicated for BMG, and failed optical ureterotomy is one of the indications for buccal graft urethroplasty. Certain cases of hypospadias also we can think of doing BMG. What are the types? The excision anastomotic, we basically do it for traumatic strictures, and augmentation or substitution urethroplasty, what we routinely practice for inflammatory strictures. What are the options for augmentation? There are multiple options described in the literature, but why the buccal graft has gained popularity? Because the epithelium of the buccal graft is as same as the urethral epithelium, which is non-keratinized stratified squamous epithelium, which is easily available and with a minimum Harvard site morbidity. It is compatible with the wet environment. So when we take it from the buccal to the urethral environment, so it doesn't changes its properties much. Also, it has got a thick epithelium and a thin lamina. So we can trim that graft into a thinnest possible without hampering its vascularity. And there is now enough data, long-term data is available to establish its outcome. What are the steps or what are the precautions we should take while taking a graft, BMG graft? That practically or ideally there has to be a two surgeon team approach where one surgeon will perform a donor graft harvesting, other will do urethroplasty with a separate set of instruments and a trolley to avoid contaminations. General anesthesia is preferable with nasal or oral tube, depend on the preference and the how many grafts are required. Throat pack is essential to avoid any spillage into an airway. Appropriate retractors are required. How much to harvest depend on how much length we required for urethroplasty. Ideally we should harvest little extra on length, 20% at least, and 15% width than our requirement. We should mark the our harvest site and also mark the site of tension duct. Should infiltrate lignocaine along with adrenaline to avoid the bleeding. Take appropriate stay sutures and use of bipolar is recommended after the harvest. Whether to keep open graft site, the donor site, or to close is a matter of debate. One should go for, there is no any side to side advantage over one or the other. Now which technique to go? There are multiple techniques. In penile stricture there is no much confusion. It is said and it is indicated as per the guidelines which was published in 2021 as per Indian Journal of Urology, and also a treatment algorithm which is mentioned in 2022. So what it says that in penile urethral stricture, whenever there is a lumen diameter is more than 4 French and without any lichen sclerosis or BXO, single stage dorsal only urethroplasty is the preferred treatment of choice. When there is a narrow lumen less than 4 French or in presence of BXO, we have got two options, either to go for a stage urethroplasty or also an option of dorsal only urethroplasty with unilateral mobilization as described by Dr. Kulkarni. There is lot of theories or lot of advances, lot of procedures are coming in bulbar strictures. So it is said that whenever the stricture length is more than 2 centimeter and we have got a good lumen more than 4 French, either venter or dorsal only should be considered. But if the stricture length is more than 2 centimeter and the stricture is near obliterative or obliterative, then we have got option of only double face urethroplasty. Yes. Now less than 2 centimeter with a good urethral lumen more than 4 French, then there is a new role is coming with non-transecting urethroplasty. But if the stricture is occlusive and less than 2 centimeter, then still we have got option of excision and primary anastomosis. This is how this BMG augmentation has evolved over a period of time since 1996 up to a newer mucosa sparing non-transecting technique as described by Dr. Kulkarni in 2022. Now briefly about techniques. Dorsal only technique is indicated for a bulbar stricture more than 2 centimeter and lumen more than 4 French, and any length of penile stricture who has got a good lumen more than 4 French. So there are initially the basic technique is described by Barbagli in 96 that the spongiosum is entirely mobilized all around and a dorsally we have to suture the graft and the stricture segment is open dorsally and fix the edges with the graft. This is the original technique described by Barbagli. Dr. Kulkarni has modified this technique, as everyone knows that what are his modification? He mobilized the spongiosum on one side only to preserve the opposite side blood supply, so that the risk of erectile dysfunction or sexual dysfunction is less and the post-op chordae or induration is less. So this is a example of anterior strictures starting from mid penile to a pinobulbar junction, where we perform a whole length dorsal buccal graft, and there is improvement in the uroflow. Other technique for bulbar stricture which has got a length more than 2 centimeter and a good lumen, particularly mid and proximal, we have got another option of ventral only as described by Moore and Mechanic, where he suggested to open the spongiosum ventrally and put a graft like an onlay, ventral onlay. He doesn't disturb dorsally, he doesn't take any incision dorsally. What are the disadvantages of this technique is in a long term, as there is no lot of support, there is chances of a diverticulum or some pseudo diverticulum formation. Another technique by Asopa, where he opens the spongiosum ventrally and incises the stricture dorsally and put an inlay. Double face is indicated when the bulbar strictures are more than 2 centimeter and there is a narrow lumen, say less than 4 French, where a technique described by Dr. Kulkarni is where to dissect the spongiosum dorsally, open the stricture dorsally, put a graft on the spongiosum dorsally and excise the stricture segment ventrally and put a graft there also. So double face. This is the post URP stricture, nearly obliterative, where we put a dorsal graft as well as a ventral graft. So double face urethroplasty has been performed. Another double face approach when there is bulbar stricture more than 2 centimeter with a narrow lumen, which is a ventral approach as described by Palmentary, where he doesn't dissect dorsally, he opened the spongiosum ventrally, he incised dorsally the stricture segment, he put an inlay there and then put a ventral onlay. So here the dorsal inlay and a ventral onlay is a Palmentary technique. Recently, many papers and many modifications are coming on these strictures less than 2 centimeter with a narrow lumen. Many people are suggesting different modifications. So dorsally, for this a non-transecting bulbar urethroplasty, where to go a dorsal dissection of is indicated, where you have to open the spongiosum dorsally and then assess the strictures. If there is mild spongiofibrosis and the mucosa is very pliable, then we can just, if the stricture is very narrow, less than 2 centimeter, we can just take an longitudinal incision and close it horizontally. So which is an Hennig Mikulicz technique. If the spongiofibrosis is moderate, if the mucosa is not pliable, so at that time we need to excise the stricture segment or the scar and put a double face, the dorsal graft as well as the ventral. So as the technique is described by Kulkarni as well as Wake and Kodama. Marx et al. Describe the same technique, but his approach is to go ventrally. He doesn't dissect it dorsally. And when there is severe spongiofibrosis, unable to dissect only a scar tissue, then there is option of excision primary anastomosis or a Jordan modification. What is Jordan modification? He tend to preserve the bulbar vessels on both sides and do excision and primary anastomosis. Another option is to close approximate the spongiosum on one side and put a graft on other side. That is anastomotic augmentive urethroplasty, or other option is double face. This is the same technique I have already described by Marx, that is the ventral approach for nearly obliterative bulbar strictures, where he opened the spongiosum ventrally, then put a ventral approach, dorsal scar is excised, and he used to do a mucosal approximation on the dorsal side and put a ventral onlay. Mucosal sparing non-transecting bulbar urethroplasty by described by Kulkarni, Dr. Kulkarni in 2022, where he don't put a graft, he just approximated the mucosa either on both sides or one side depending on the location of the stricture and the pliability of the mucosa. He has suggested is one of the option. what is the advantage of this non-transecting bulbar urethroplasty, as it is now clearly evidence that it preserves the efficacy like end-to-end urethroplasty, but reduces the post-op recurrence of erectile dysfunction. Now there is clear-cut evidence that it certainly reduces the incidence of ED. How do you define a failed urethroplasty? After surgery, when the uroflow is less than 15, or when there is need of any additional procedure like dilatation or VIU or any other redo surgeries, or when there is radiological evidence of stricture. This is very interesting that up till now we used to know that urethroplasty has got very good success, nearly 85 to 90%, but that was all intermediate success up to 5 years. All studies like Campbell et al. Has mentioned in 2014, and there is a Mangera review 2011, that the intermediate success of single stage urethroplasty is 83 to 88%. But now there is a good meta-analysis and a systemic review has come up in 2021, which has mentioned and which has studied the 10 studies over 90-50 patients, and what they suggest that as the duration increases, the success rate of the BMG urethroplasty goes down. What they quoted is at 10 years the success is only 58, and at 15 years it is 45. So this is very important to counsel the patient while performing urethroplasty, a long-term consequences and a prognosis. Thank you so much.
Thank you, Arun. Any questions from the house? I would like moderators to add.
I think Dr. Gita has got a lot of experience. Oh, no, let me. Though we have been working together for a long time and done more than 200 BMJ graft urethroplasties in GMC. After he shifted to Bombay, instead of doing visual internal ureterotomy, what you call as DIB-UIU, he started doing non-transactional urethroplasty for occlusive urethral strictures. I think I don't have experience of that. I will ask him or request him to add his experience in this subject.
Sir, overall, today's topic, stricture, for to label it as a stricture, there should be spongiosa, corpora spongiosa. So the stricture, it arises from meatus to the membranous urethra. Membranous urethra, there is a stenosis because there is no spongiosa. Whatever the investigations he has quoted, important, the crux of the story is how much is the spongiofibrosis. The spongiofibrosis only going to decide the treatment. Rest all are not that significant. Okay. So to assess the spongiofibrosis, along with clinical examination, uroflowmetry, palpation, जो भी है वो सब उसके साथ ultrasound, which usually we doesn't do ultrasound. We take our clinical experience only. But that ultrasound, which will definitely decide the site, degree of the spongiofibrosis, site of the spongiofibrosis, and periurethral, all pathologies can be well judged by the ultrasound. So in deciding if you want to do endoscopic treatment, and if you have not done ultrasound prior, then it is going to fail. So I am writing next incoming IGU editorial. I have invited to write the editorial about the same topic. So if you have not done MRI, again he has not mentioned about the MRI. Whenever you suspect a malignant stricture, so to assess the malignant stricture, the best investigation is MRI. Which is the best investigation to diagnose the stricture is scopy. nothing is better than the scoping. So this is in short about the diagnosis. As far as dilatation, DVIU and adjunctive procedure is concerned, dilatation is a palliative treatment. So the purpose of doing a dilatation and DVIU is making a small tear in that stricture in hope that the stricture will epithelize faster than the fibrosis. But it doesn't happen like that, because you don't know how much is the underlying spongiofibrosis. You cut visually or blindly or with a coaxial dilator or with a blind dilator, then that will create a small tears. That will stretch, dilatation will stretch the stricture and cause a small tears. Okay. So that tear may not heal with epitheliation only. So there is no role of dilatation at present. Dilatation and DVIU is used only as a palliative. Direct visual internal urethrotomy and dilatation has equivalent result at the end of 4 years. So initially we used to do VIU right and left. Now, n number of studies, 97% of the urologists across the world 10 years back doing the VIU, and now it is going down to 67%. Because more superior alternatives are available. So if you want to go with endoscopy only, the Optilum is a better alternative than the DVIU or dilatation. So all guidelines, AUA, EUA, Indian, DVIU as well as dilatation, palliative treatment, grade C recommendation. So then to do a DVIU or not. So if you are that much expert in selecting a properly selected patient, less than 1 centimeter, bulbar, soft, non-obliterative, primary, that is first, then without spongiofibrosis, तो ये तो ऐसा इतना आइडियल पेशेंट ढूंढते ढूंढते नहीं मिलेगा वो. The chances of doing a DVIU success initially quoted as 0 to 45%. Now current literature says 0 to 9%. And at the end of 3 years, that 9% will go down to 3% or 4%. So for that small stricture, a number of alternatives are available, like non-transecting arthroplasty. I have done at least 50-60 non-transecting arthroplasty till date. Results are good, but that there also we have to select the patient properly. When you are doing any arthroplasty, you open dorsally only. Because if you open ventrally, you committed to only 2 procedures. One is onlay and another is inlay. If you open dorsally, you have n number of options. Okay. So, as far as inflammatory stricture is concerned, if it is a penile, single stage procedure is always better. It may be dorsal only, it may be lateral only, or inlay, asopa inlay, with Barberini circumferential dissection or Kulkarni one-sided dissection. If it is a severe panurethral stricture, then 2-stage procedure. Doing a 2-stage procedure is not wrong in current situation also. Okay. So doing a dorsal only with the 4 French lumen is like a mismatch marriage. Theoretically it may be correct, but if you apply dorsal only with BMG to that 4 French, it will not work. Because you cannot take that 4 French sutures on both sides. So it should be either, Kulkarni sir also tell, it should be at least a 6 French ureteroscope go across to do a BMG. And if it is less than that, then double phase. So double phase already he has explained. Then adjunctive treatment. Now tissue engineering as well as stem cell therapy and intranasal therapies. Since many years it is going on. Like captopril, intraurethral brachytherapy, in past they are tried. Now mitomycin C has a good result. Optilum has a good results. But still it is not recommended by any guidelines, and all the things are under trial. So best way to have a good result, you go ahead with urethroplasty. And in a patient who is unfit for surgery, and if you want only a stopgap arrangement, then do dilatation, VIU multiple times. Single VIU for properly selected patient is ideal. The patient should be ideal. Second VIU, again success rate goes very slightly severely down, and there is no role of third VIU. Now people are saying there is no role of second VIU also. So we are stopped first VIU also. Because you have a number of options. So alternative to that BMG, again bladder mucosa, rectal mucosa, veins are, everything is under trial. Nothing is proved better than the BMG. If there is a non-inflammatory stricture, near about 85% success rate compared to the 93 success of that BMG with inner prepuce. That is also particularly patient BMG is not good. And try inner prepuce. That is one of the best option. Second to the buccal mucosa or lingual mucosa. So urethroplasty is very interesting. Always try to do it primarily. And that is one first chance is a golden chance. And if you want to bring that patient repeatedly to your clinic, then VIU is one of the best options.
Second thing is that I think we should talk about little bit more about posterior urethral strictures. It's a very common topic, very difficult to treat. It is a thermal injury, equally common with lasers, and difficult to treat. So if you can, either Dr. Chinchole or Dr. Geeta can add some more light on that.
Usually if the patient is obese, if it is a post-URP, and if it is a proximal valvar, always try ventral only. Don't do dorsal only. It is very difficult to go behind and place the buccal mucosa. So post-URP stricture, proximal valvar, ventral only, mid valvar or distal valvar, dorsal only, lateral only. And meatal strictures, inflammatory, no role of dilatation. Start with meatotomy or meatoplasty. It will definitely recur. 100% time it will recur.
The boss has spoken, so I won't be able to add anything. Just for the sake of residents, there is some role of flaps which has not been mentioned during the discussion that they should remember. That's it.
Another thing is VIU. So it should be a single incision, it should be a multiple incision, it should be a dorsal incision, ventral incision. The topic is going on. So olden concept is to take the tolocloac incision because there is 3 and 9, there is vessel. So to avoid the bleeding, you are taking a tolocloac incision. If you take that in depth, that will cause a spongiocavernosal fistula and severe bleeding. If you take, so alternative to that, people tried 3 incisions. That is very superficial. 12 and 6 and 5 or 7 or 6. Now we are trying ventral VI. So I have done 5 cases still. It is difficult because doing a ventral VI with current instruments is you have to rotate 360 degree and take the incision. But as such, VI has a questionable role.
Thank you, sir. I would like to call upon Malik sir to felicitate our moderators, today's moderators. Thank you, sir. There is a small announcement that Aurangabad Urology Association and MGM Urology Department we are organizing a one-day semi-live focus symposium on renal malignancy and prostate cancer on 1st September 2024. It is a Sunday. For this program, Dr. Yuvaraja has given a consent. So when Dr. Yuvraj is coming, so we are trying for one more person. So two faculties we are looking forward. No, this is semi-live. It's a symposium. They will be only these two topics will be covered in depth. So for today's next program, I would like to call upon Dr. Onkar for a small talk on management of LUTS associated with BPH and role of silodosin mirabegron.
Good evening everyone. So topic is management of LUTS associated with BPH and role of silodosin plus mirabegron combination. ये नेक्स्ट नहीं जा रहा एक मिनट वो उसके मिल गया ऑलरेडी ओके तो ये क्लोज करना पड़ेगा पहले तब अभी एक मिनट डुप्लीकेट कर देता हूँ. So what is LUTS? It is defined as symptoms that result from condition and disease affecting the bladder and the urethra. It comprises of storage symptoms, voiding symptoms and post-micturition symptoms. LUTS is because of BPH, then detrusor overactivity, underactivity, then it may be neurogenic cause, any urinary tract infection, urethral stricture or any tumor. Mechanism of LUTS in BPH is mainly because of two reasons. There is a static factor and a dynamic factor. Static factor is mainly because of compression by the growth, whereas dynamic factor is because of smooth muscle contraction. So the drugs that act on the static factors are 5-alpha reductase inhibitor, drugs like dutasteride and finasteride, which helps in decreasing the growth of prostate, whereas tamsulosin, silodosin, alphazocin, which are alpha blockers, and tadalafil, which is phosphodiesterase 5 inhibitor, help in smooth muscle relaxation. Another reason of lower urinary LUTS is overactive bladder, which is managed by beta adrenoreceptor agonists such as mirabegron and muscarinic antagonists such as solifenacin, darifenacin. So conservative and pharmacological treatment. The recommendation for mild and moderate symptoms in which the patient can bother without any disturbance in their daily life, there is strong recommendation of conservative management. Also alpha blocker to men with moderate to severe LUTS, there is strong recommendation of giving alpha blockers. Also patients with prostate volume more than 40 cc and moderate to severe LUTS symptoms, 5-alpha reductase inhibitor should be added to them. Alpha blockers, they act by reducing the muscle tension in prostatic stroma, bladder neck and urethra, improving both storage and voiding LUTS. Alpha blocker like prazosin, alfuzosin, doxazosin, terazosin can be used. Silodosin is more efficacious within 2 to 4 hours of administration. So it can be used in conditions where there is impending retention of urine or if there is a trial without catheterization is planned. So which alpha blocker is more efficacious? So according to this graph, silodosin being more effective as it binds more effectively on alpha 1A blockers, Alpha 1A are more on prostate, Alpha 1B on blood vessels, and Alpha 1D on bladder. Silodosin has more affinity. It is 162:1 for Alpha 1A receptors, whereas tamsulosin being 9.5 is to 1. So silodosin has 17 times higher affinity for higher selectivity in compared to tamsulosin. Choice of alpha blocker. It depends upon the socioeconomic profile, the availability of the drugs, and the clinician's experience. How long an alpha blocker can be given? Some studies recommend that it should be withheld when the LUTs are not bothersome. Some also say that the alpha blockers over 6 years has a sustained efficacy. The need for combination of silodosin and mirabegron. What are the indications? It is above the age of 50 years. Prevalence of LUTs is 30%. 14% of patients with LUTs have BPH, and 50% of patients with BPH will be having overactive bladder. So alpha blocker being the first line therapy can be added with antimuscarinic for treatment of overactive bladder. But as antimuscarinic has its own side effects, so mirabegron is alternative option which is proven efficacy in both men and women. So USI guidelines in BPH 2021 has a strong recommendation of using antimuscarinic agents in combination of alpha blockers. But in cases of in patients where the post-void residue is more than 150 ml, the recommendation level is conditional or selective. Then EAU guidelines, has a strong recommendation. Even American Urological Association has strong recommendation with a grade C evidence. Mirabegron is a beta-3 adrenergic receptor agonist. It has a 150-fold higher affinity for beta-3 agonist and relaxes the detrusor muscles and helps in improving the symptoms. So combination of silodosin and mirabegron is helpful in patient of BPH with overactive bladder. So 50% of patients with BPH and BPO have overactive bladder. Alpha blockers as a first line therapy along with mirabegron as an alternative to antimuscarinic for overactive bladder is preferred. And it is recommended by EAU, AUA and Canada Urology Association guidelines on treatment of BPH 2022. Thank you.
Thank you, Umkar. Now I would like to call upon Panditkar sir to felicitate Dr. Ajay Oswal sir. He has successfully conducted the KTCon Bhubaneswar. The photos. Sir, these are the photographs, the trophy which is presented, and there was the symposium went on in Aurangabad Urology Association symposium's name, and this year the topic for the symposium was stones in kidney donor and recipient. And for that session, the convener was our Dr. Abhay Mahajan sir. The felicitation will do it in the next meeting. Yeah. So for this workshop, I forgot to tell that next month we will not have a meeting, our monthly meeting. We will directly have this symposium on 1st September and then third week of September we'll have another next meeting. So with this I conclude today's meeting.